I was tasked with talking about whether the treatments in the treating multiple myeloma, whether less is more. In many of the hematologic malignancies with advances in treatment, the treatments are more tolerable with better side effect profiles and more effective. So the former model of more aggressive therapy resulting in better outcomes for our patients may not necessarily hold true. And so in my talk here at SIOG, I have been focusing on the studies which have indicated that a more aggressive approach does not benefit our patients. Conversely, there are some studies that show that, that more aggressive treatment or longer duration of therapy or maintained dose intensity do benefit our treatment. The literature varies depending on the toxicity of the treatment. For example, in a study known as the Upfront study with the first author of Nisvisky from JCO in 2015, in a randomized trial they demonstrated that there were similar response rates, progression-free and overall survival, whether the patients received bortezomib and dexamethasone alone or in combination with melphalan or in combination with thalidomide. And so in that case, patients treated with bortezomib and dexamethasone alone didn't benefit from the addition of an additional agent. Conversely, in the first trial, published by Ben Bucher in the New England Journal in 2014, patients who were treated with lenalidomide and dexamethasone continuously had better overall survival, progression-free survival, than patients treated with a finite duration of lenalidomide and dexamethasone, truncated at about 18 months, or with melphalan, prednisone, and thalidomide truncated at 18 months. So patients treated continuously with a very tolerable regimen had an overall survival benefit. Absolutely. I think that attention to the balance between efficacy and tolerance of therapy are going to be the real hallmark of treatment of multiple myeloma. And the first trial, for example, will be a very, very important trial in demonstrating the importance of continuous rather than interrupted therapy. A very good question. So I think the role for immunotherapy in the setting of multiple myeloma is still evolving. Nivolumab was shown to have no single agent activity, but I think that there's a lot of interest in seeing how the immunotherapeutic agents will work in concert with our existing platforms, such as the immunomodulatory agents. I think that there's going to be a lot of interest in and hope for that, the combination as opposed to the single agent activity. In addition, the new generations of medications, including daratumumab, which was studied in the Castor and Pollux trial, did look at subgroup analysis for whether there was an interaction with age. And across all of the newest studies, including the Castor, Pollux, Evolution trial, and so on, they have demonstrated that the older adults in those clinical trials benefited to the same degree that younger adults benefited in those studies. We have to keep in mind, though, that the inclusion criteria for clinical trials often are really tailored towards the fittest of the fit older adults. And so ultimately we'll want to replicate those findings in more vulnerable populations, demonstrating their efficacy while maintaining a good safety tolerability profile in our more vulnerable older adults with multiple myeloma.